Morning, good afternoon, and good evening to all the trainees all over the world based upon the place where you are logging in. Today, we are doing the 69th episode of our urology exam preparation, and we are doing some exam scenarios in penile cancer. We have our trainee volunteers to discuss the scenarios. Welcome. Your time starts now for the first scenario. You have a 22-year-old gentleman presented to your outpatient clinic referred by GP with history of a kind of elevated irregular lesion in the inner side of the prepuce. How are you going to evaluate him? Any one of you?
So I will see this gentleman in my 2 weeks clinic along with the CNS specialist nurse, and then I will take the history. In the history, I will take the duration of the lesion and any bleeding or painful, whether he got a treatment before or not. Then I will ask for the risk factors such as phimosis, circumcision, multiple sex partners, which may be due to the HPV 16 or 18 exposure, and HIV also status, and also the risk factor of the smoking. And then I will ask about the general conditions, any comorbidities, and then I will any medication allergies, and then we'll move on to examination. In the examination, in the presence of chaperone with the verbal consent, I will see the lesion, I will retract the foreskin, see the size and site of the lesion, see the glands, and see the urethral meatus as well, and I will palpate the inguinal lymph nodes and take it from there.
Okay. The evaluation shows that his penile shaft is normal. There is a lumpy elevated lesion in the inner side of the prepuce. Otherwise, his examination is normal. No lymph nodes palpable. He has no significant positive past history.
So in that case, I will offer this gentleman the circumcision on radical circumcision on the urgent basis, and I will take it from the histology from the.
What are all the histology possibilities you are expecting in this gentleman?
The histology will be he's a 22 years old and most likely could be benign or the malignant. In the benign, it will be the some skin lesions, or in the malignant, it will could be the penile cancer.
So, what possible penile cancers can present like this?
Uh, it will be the squamous cell carcinoma.
Okay. And what is the difference between the radical circumcision and the normal circumcision which you do day in, day out?
In the normal circumcision, we stitch the inner foreskin, but in the radical, we take out the whole inner foreskin out.
Why is that?
Because the inner foreskin it harbors the pre-malignant HPV 16 and 18 virus, which are the risk factor for the cancer.
Okay, how are you going to follow him up? Your biopsy showed like a PTA lesion, low grade.
So PTA low grade in CN. So I will follow up. My follow up will be the local on the penile, and then the follow up of the lymph node. So in that case, I will ask the patient that he should examine his lymph node and also the penis, and I will see him in my clinic 6 monthly until 2 years, and then annually after 3 years, and until 5 years, and then discharge him if there's no recurrence.
Okay, you are following him up. The first two follow ups were quite okay, but on the third follow up, which is almost in a year's time, he developed another similar lesion on the glans surface, exactly opposite to the place where you excised his preputial lesion. He had radical circumcision, now he has the lesion in the glans.
So again, I will stage him with the history, with the examination or the local, and then also I will do the lymph nodes examination. And if lymph node examination says no involvement, then I will offer him the wide local excision of the glands depending on the size of the lesion, or the other. If it's bigger, then the glandsectomy with the skin regrafting is another option, and I will follow him up with the result of histology.
Okay, the lesion measures easily almost 10 millimeter. It is away from the meatus. The rest of the glands normal. So, what is your plan?
So wide local excision is an option for him because he's young, and the penile preservation surgery is better for him.
Okay. What about lymph nodes? What are you going to do?
The lymph nodes, as I told, that if it is normal, but if it is, then the lymph node strategy will be depending upon the histology. If it is a PT1B or high grade, then I will offer DNSB, the sentinel lymph node biopsy.
What is DNSD?
DNSB is a dynamic sentinel lymph node biopsy in which we inject the radioactive technetium 99 nanocolite around the tumor, and then in the department, the radiologist he marked the sentinel lymph nodes, and per we give methylene blue at the induction peritumorally, and then we do the lymph node biopsy with the gamma camera, which is the most taking the highest tracer in the lymph node. And I know that it is a 5% negative chances of getting the lymph node because of tumor burden, but intraoperative ultrasound scan probe can eliminate this problem.
Okay, what do you mean by peritumor? As I told you, the tumor is present at 9 o'clock position when you are sitting and examining the patient. So,
Mm.
what do you mean by peritumor injection?
It is on the around the tumor.
Okay, is there any imaging needed for the penile shaft?
A penile shaft, if we're doing the penile preservative surgery, then yes, we do the MRI scan with the PGE1 induced erection.
So, what is your plan for this patient, surgical wise?
Though surgical wise, because a small lesion and the lymph nodes are negative again, I will see the histology and take it from there. What was my histology on the redo surgery?
Okay, so you are excising the lesion. The lesion comes as T1 and highly differentiated. And how are you going to take it forward?
So it's a highly differentiated. So it is a low grade T1. So I will again follow him up with the observation of the inguinal lymph nodes, and with the local examination of the gland penis. Again, my follow up will be the first 2 years, first year 3 monthly, second 2 years 6 monthly, and then I will discharge after the 5 years if there is no recurrence.
Do you aware of any non-surgical management of the superficial penile lesions?
Yes, the non-surgical management will be the topical chemotherapeutic agents such as 5-FU topical Micomode, or the laser carbon dioxide laser ablation, which comes into the minimal invasive anyway, and then the gland resurfacing, which is the surgical.
So, what do you mean by glands resurfacing?
The gland resurfacing, in this we will shave away the epithelium of the glands, and which is replaced by the superficial skin graft from the thigh.
Do you know about Mohs micrographic surgery?
Most it is quite extensive, and nowadays it is not in a practice because of the increased comorbidities.
Okay, why? What is the surgery? Why it is discontinued?
Because it needs to shave off the deeper structure, and we have to stitch the put the skin full thickness skin graft.
If you are doing glands resurfacing, how are you going to plan that?
My planning will be that I will explain the patient that he has to, we will shave off the glands completely, and then we will take a split skin graft from the thigh, which will be stitched over the glands and dressing is done, and I will take it off in about 10 to 2 weeks time, and then we take it from there.
Why are you doing split skin graft? Why are you splitting it?
Because the split skin graft, uptake is better. I know that it is a more chances of having the fibrosis and shrinking, but it's better in cosmetics, and uptake is better in this.
Do you have to do anything for the urethral meatus?
Urethral meatus, if it is not involved, then I will or don't leave. I leave it alone, but we will put a catheter when I'm doing the
Okay,
graft.
good. Well done. So this is one of the very common scenario. They will discuss all the superficial and penile lesions, and they may even take you to the various possible benign and pre-malignant lesions. So just be very careful with like erythroplasia of Coirat and various other pre-malignant lesions. Maybe there may be one question with that. In radical circumcision, the reason why we are removing the complete inner surface of the perpuse 360-degree is this lesion is a multifocal disease. And once a patient is exposed to the herpes virus or any other etiological factors, there is a possibility of recurrence. And just like bladder TCC, we always treat the whole bladder, maybe a multifocal disease. So we are trying to prevent further recurrence by removing the complete inner surface of the perpuse. Regarding the split skin, the one reason is if you make the split in the skin, if there is any exudates between the skin graft and the bed of the area, the split will help for the exudation of the collections. So if not, if there is no split, the exudates can cause raising of the skin graft from the bed, and that can result in the loss of the skin graft, and it won't take properly.
Yeah.
So that's why we are doing the split screen, so that the exudates are taken off and the graft is nicely fit into the bed, and there is a neovascularization and imbibition of the graft. Okay,
Yeah. Yeah.
good. Can we go for the next scenario?
Yes, I'm ready. Thank you.
Good. Your time starts now. You have a 45-year-old gentleman presented with history of a lump in the distal penile shaft. How are you going to evaluate him?
I will see him in the 2-week wait cancer clinic. I'll take a focused history, examine him in the presence of chaperone. In the history, I will focus on the onset and duration of the lump, any associated pain, any associated urethral discharge. I'll also ask for any risk factors like any previous history of HPV, multiple sexual partners, history of any ultraviolet radiation treatment, his medical comorbidities, the medications he's on, previous surgical history, and social history for smoking. I'll move on to the examination in the presence of a chaperone. I will look into the mass and see the size and note the size and position, and in relation to the meatus, in relation to the coronal sulcus, and if there is a foreskin in relation to the foreskin. I'll also see whether it is involved, whether it is fixed mass, whether it is involved in the corpora or urethra. Moving on, I'll examine the rest of the shaft to see if there are any other nodules in the shaft, and also examine the bilateral groins, and we'll examine the testicles and DRE. That will be my initial approach.
What do you mean by the ultraviolet treatment? What treatment he may have had?
So Soralen pure therapy is known to have a risk factor to cause penile cancer, squamous cell carcinoma.
Okay. What type of herpes virus can cause squamous carcinomas?
HPV 16 and 18 is known to cause squamous cell carcinomas.
Okay. On examination, he is well built. His BMI is 33, and his penile shaft showed obvious mass lesion in the distal penis. Examination wise, you are convinced it could involve the corpora cavernosa, urethral meatus is involved, and somehow he is passing urine comfortably, and bilateral test is normal, no inguinal lymph nodes palpable.
Okay. So in this condition, clinically it appears typically like a penile cancer, even involving the urethral meatus. So I will make arrangements for him to be referred to a supra-regional MDT. I'll contact the supra-regional MDT team, and we'll make a urgent referral. It needs to be discussed there. In the supra-regional MDT, I think they will go for possibly a biopsy, but if it is really typical, then they will go for a MRI scan. It will be a PGE1 induced erection of the penis and seeing the tissue planes involved. And if it is depending on the involvement of the corpora cavernosa or urethra, it could be either a glandsectomy or a partial penectomy. And further afterwards, depending on the histology, we will stage the lymph nodes as well.
Okay, the tumor involved the corpora cavernosa in the MRI scan, and you are planning for partial penectomy. How are you going to plan that?
In a properly consented, draped and prepped and draped patient, after giving the antibiotic prophylaxis, a penile block is given, a tunic is applied to the base of the penis, and a sterile glove is applied and draped over the lesion. The initial incision is circumcoronal, at least 5 millimeter beyond the visible margin of the tumor. And the incision goes all around through the layers of the penis, like skin, buccal fascia, tunica albuginea, and corpora cavernosa. And the principles are, after removing the whole tumor, the urethra has to be spatulated to avoid any urethral stenosis, and usually a catheter is kept. But if it is a good meatus, then we don't have to. And yeah, so that will be the principles for a partial penectomy.
What is the margin you will be planning?
Ideally, the margin should be 3 to 5 millimeter. If it is an aggressive tumor, then 5 millimeter is the ideal margin.
What type of reconstruction available for him?
For the ideally, there should be at least 2 to 5 centimeter of the penile shaft that we need to preserve for a proper voiding. And the reconstruction, it could be, if primary closure is possible, then that is an option with splaying of the distal end of the urethra. If primary closure is not possible, then we will use split skin graft to cover the defect and then stitch the edges of the skin to the edge of the corpora.
Okay. Intraoperatively, this is an obvious common cell cancer involving the corpora. You can feel it with your hand when you are doing the dissection. Surgery went well. What type of histology you are expecting in this patient?
I will expect the squamous cell carcinoma, common type.
What may be the staging you are expecting?
It will be, it is involving the corpora cavernosa, so it will be T3. And depending on the grade of the histology, I'll have to see that as well, and also to see if there is any variant histology.
What variants possible?
So basaloid and sarcomatoid are the aggressive type of penile cancer. So if these are there, then I have to have an aggressive approach for the inguinal nodes.
What type of grading is possible of tumor?
4 types, 5 types actually: GX, G1, G2, G3, and G4. GX is when the grade cannot be determined. G1 very well differentiated. G2 well differentiated. G3 moderately, and G4 is poorly differentiated.
Okay, his tumor is G4, poorly differentiated, with pathological T3 involvement of corpora with some evidence of basiloid changes. So what is your plan?
So he needs staging of the bilateral inguinal lymph nodes. If I believe the lymph nodes are clinically not palpable, so in that case, it is a twofold approach where we'll send the patient for an ultrasound scan of the groin and for a FNAC if there is anything, any abnormal nodes there. At the same time, we will also arrange for a dynamic sentinel node biopsy. If the ultrasound scan and the FNAC shows any involvement of the nodes, then radical inguinal dissection is done on the ipsilateral side. If it is negative, we'll proceed with the bilateral dynamic sentinel lymph node biopsy.
What do you mean by radical lymph node dissection? What are all the principles?
In the radical lymph node dissection, all the involved packets of nodes, superficial and deep, are removed in the inguinal region. So according to the Dressler's node zone, superomedial, superolateral, inframedial, infralateral, and the Clockett's nodes are removed. The boundaries are medially adductor longus, laterally sartorius, and superficially 5 centimeter above the inguinal ligament, and distally up to the level of the foramen ovale. The principle is all these node packets are removed. However, we'll try to preserve the saphenous vein and also try to avoid the transposition of sartorius if possible. If not, if this extensive node dissection is needed, then our primary aim to remove all of the lymph nodes in the inguinal region.
Why do you want to preserve the saphenous vein?
It is to prevent, because if we preserve the saphenous vein, the comorbidities of the radical inguinal dissection is less, and the lymphedema is less compared to an extensive dissection.
Why you don't want to transpose the sartorius? Sartorius is always good in protecting the vessels.
Yeah, so in that case also, ideally, if it is a complete lymph node dissection, then the vessels are really exposed, and most of the time, if the vessels are completely exposed, it's ideal to transposition the sartorius. But if there is not much of vessel exposure, then possibly we can think about not transpositioning the sartorius, but it's a usual practice to transposition it.
How are you going to stage is pelvic lymph nodes?
Depending on the histology of the dynamic sentinel node biopsy, the radical inguinal node dissection, if more than 2 lymph nodes are involved, or if there is extranodal extension of the lymph node, then we have to go for the ipsilateral pelvic lymph node dissection. Pelvic lymph node dissection is also done if there is any imaging evidence of enlarged pelvic lymph nodes.
So what is the extent?
Extent of pelvic lymph node dissection is superiorly the division of the common iliac vessels, laterally genitofemoral nerve, medially the lateral border of the bladder, and distally Clockett's nodes.
Okay, good. We'll stop there. Again, a very straightforward scenario. As you all know, penile cancer has got only like from something like a low stage to high stage, 3 to 4 scenarios. The lowest one is the one scenario where they discuss lot of pre-malignant lesions, which is a little bit boring because it's more of like a dermatology clinics rather than urology. But as you go to the higher stages, it's more clinical and surgical, and it's quite interesting. I'm happy. Any questions before we go to the next scenario?
Yeah, so regarding the radical dissection, is it always be transposition sartorius, or can we modify it according to the surgical field?
We can modify. I mean, how we have to decide is based upon the intraoperative findings. If the vessels are really skeletonized, it's better to transpose the sartorius because it will prevent the unnecessary complications of blowing out of the artery or the vein. But if you think that the vessels were quite deep enough and nicely preserved, you can avoid sartorius transfer. But the most important thing is the cancer clearance. So once the vessels were nicely skeletonized and even the vein preservation, it all depends upon the cancer clearance. If you can't get a plane, and if you think the vein adventitia are involved by the lymph nodes, then we need to sacrifice the lymph nodes also. Okay.
That's great. Thanks so much.
Yeah, we can decide based upon how much clearance you made. If the vessels are really skeletonized, you need to transpose the sartorius. It involves a kind of a discomfort and pain and increased morbidity, but the mortality due to blowing out of the vessels in the post-op period is much more worse.
Sure. Okay.
Okay. Can we go for the next scenario?
Yes, please.
Good. Your time starts now. The same patient, we are continuing, and opposite side, the side where the trainee did the radical surgery, the ultrasound showed presence of the lymph nodes, and FNAC also proved the spread and hence he did the radical surgery. What is the plan for the opposite side? Ultrasound didn't show any enlarged lymph nodes.
So I would want to know the state of the opposite side. So this patient, I want to review result from, ultrasound did not show any enlarged lymph nodes, so the patient will require dynamic sentinel lymph node biopsy. The other thing I want to know about the ipsilateral lymph node is, the unilateral lymph node is, if there is any extracapsular spread. If there is any extracapsular spread from the lymph node, then it's already a T3 disease. It is important to get the state of the lymph node, but it will be more important to know the state of the pelvic lymph node. So for the contralateral lymph node, I would organize a dynamic sentinel lymph node biopsy. Or when the patient is having lymph node dissection on the side with positive lymph node, I would want to also look at the other side by doing on-table sentinel, modified sentinel lymph node, sentinel lymph node biopsy. That is giving methylene blue, patent V blue, and looking for area of blue uptake to see if that lymph node needs coming out.
What is the role for the radionuclide studies?
So radionuclide study will also be done on the day of the operation, on the day of the radical lymph node dissection. And if it shows any area of uptake, I will also combine with a patent blue to see if that corresponds to area of uptake, and all the blue and hot lymph nodes will need to be sent for frozen section. And if they come back positive, then the patient will need to have the contralateral radical lymph node dissection as well.
Okay, how are you going to inject the radionucleotide on the day? How will you plan?
So this patient has already had partial penectomy. So I will just inject at the tip of the penis. I will send the patient to, it is done in radionuclear department, and it is done about 3 to 4 hours before the operation, and it involves the use of technician 99 label nanocolor, which will be injected at the tip of the penis, and this will go to the sentinel lymph nodes, and a gamma camera will be used to pick up the lymph nodes. A cobalt pen will be used to mark it. And when the patient has come into the anesthetist room, I will give methylene blue I will give at 4 sites at 12 o'clock, 3, 9, and 6 o'clock, and then we'll look for area of blue uptake.
Okay, so you're able to see an area of the radionucleotide intake and you're making a cross in the skin. How are you going to plan the incision?
So the incision will be transverse. Well, I'm not sure.
Okay, and you are taking the sentinel lymph node and which comes as positive in frozen section. What is your next step?
So this patient will require radical lymph node dissection on that side as well.
Okay, so again, what is the margins? Same margins or any changes?
Well, so it's going to be same margins, 5 centimeter above the inguinal ligament, apex of the femoral triangle, medial border of adductus longus, lateral border of sartorius.
Okay, you said to me once about the modified lymph node dissection. In which role it plays?
So modified lymph node dissection is one of the invasive way of staging the growing lymph node of a clinically impalpable lymph nodes. It is recommended by AAU. to either consider dynamic sentinel lymph node biopsy or modified lymph node dissection. So this involves, if there are no facilities for dynamic sentinel lymph node biopsy, it involves taking the superior media and the inferior media packet of superficial inguinal lymph nodes, sending them for frozen section. If they are positive for cancer cells, then the patient would have completion of the growing lymph node dissection on that side. And this would mean the superior media, the inferior media, the superolateral and the inferior lateral packet of the lymph node, not removing removing the great Savinius vein.
Okay. Why in the modified lymph node dissection we are taking only superior-medial and superior-inferior group of lymph nodes?
So it is said that they are like the sentinel lymph nodes to the penis. So any drainage from the penis will first of all get to the medial group of the lymph nodes in the superficial group before it goes to other group of the lymph nodes.
Okay, so you are doing, let us assume, a modified lymph node dissection, which is sending for frozen section, which shows positivity of the lymph node involvement, and you are converting it to a radical lymph node dissection. And how are you going to manage him in the immediate post-operative period?
So with radical growing dissection, this patient has got a high risk of lymphocyl, lymphedema, deep vein thrombosis, flap necrosis, and wound infection. So in the immediate post-op period, I will start with rehabilitation in forms of encouraging regular exercise, giving compression devices, and then I will immediately refer this patient to lymphedema nurses for further support, and then I will ensure this patient has got the DVT thromboprophylaxis as well.
Okay, and how long you'll be keeping him in the hospital? What will be your follow-up protocol?
So I would want to just ensure his progress for about a couple of days or 3, and if he's fine, I will discharge him. I will see him again in the clinic, but prior to that, I would want to review the histology of the lymph nodes that were removed in the multidisciplinary team meeting. So when I'm seeing again in about 6 weeks, I want to see his progress from operation and his recovery, and then I want to discuss the outcome of MDT with him in front of a cancer non-specialist.
What is your imaging of choice for the pelvic lymph nodes?
So pelvic lymph nodes is CT. Ideally, the patient should have CT chest abdo-pelvis, and the CT scan.
Okay. So if the pelvic lymph nodes were not involved, what is your follow-up plan in the imaging?
So I would, based on the result from the growing dissection, if there are no extracapsular spread, scan has shown pelvic lymph node involvement, it will be 6 monthly for the first 2 years, then yearly for the next 2 years, and then afterwards.
Okay. So what are all the indications where the CT scan doesn't show any pelvic lymph nodes, but you will still do pelvic lymph node dissection based upon the groin lymph nodes histology? What findings you will look at?
If there are fixed lymph nodes, if there are extracapsular spread, that is already a N3 stage.
Okay, good. Again, straightforward scenario, you should be quite confident in managing the side where the lymph nodes are palpable or seen in ultrasound, and the side where the ultrasound is negative, where you can use the dynamic sentinel lymph node biopsy. It's always better to use both the sources of technetium 99 loaded gynecolloid and also the methylene blue. And you can bring in some logistics that you will discuss with the radioactive department to make sure that the patient will go there, they will inject it, and if there is a lesion, it will be like proximal to the lesion. And as you said, if the lesion is already removed injecting at 12, 3, 6, and 9, 4 quadrants is an ideal one. And the radiologist will use a gamma colloid to locate the area and mark in the skin. And intraoperatively, after anesthesia, preparing daping, you can use the methylene blue to further super add the tracer. The sentinel lymph node, by definition, is the first lymph node which will get affected by the metastasis from the any organ. And the physiology or the principle is, once the sentinel lymph node is negative, we assume the rest of the lymph nodes are negative. There may be a minor possibility of skip lesions. That's why in modified lymph node dissection, we try to remove both the superomedial and infromedial groups so that we are absolutely sure that the lateral group of lymph nodes are not involved. We are trying not to go for an aggressive lymph node dissection unnecessarily because of the attendant pathology. Very good. We can do one more scenario. Any of you ready?
Yes, I can go for the next one.
Okay.
Can I ask one question,
Yeah.
Mr. D? So what's the role of FDG PET scan in the staging or in the surveillance of penile cancer?
Not much. It is good to give us a kind of a functional lymph nodes, but not much used because the first choice is the radioactivity based imaging. You think like this: examination first, examination using your fingers. Ultrasound is just an extension of your examination. It's not really super duper. Most of the time, very rarely only you will find something in the ultrasound, but it's not palpable, especially if the patient is thin. So examination and ultrasound are almost complementary to each other. And if you find something in the examination or ultrasound, FNAC, because you know the node, and if FNAC is positive, you will go into a radical lymph node dissection because you know there is a gland which is already involved. If these two were negative, you don't want to do something big, you want to do whatever the minimalist possible. That's where the dynamic sentinel lymph node biopsy is available. It needs both radioactive colloid and also the methylene blue. If this facility is not available, you will be going for modified lymph node dissection. Based upon the histology frozen section, you can go for radical lymph node dissection. And the lymph node dissection in a non-palpable situation will depend upon the primary histology from the penile stump. So that's it. Regarding the pelvis, if there are only two things: if the CT scan showed involvement of pelvic node, you need to do it. If the lymph nodes of the groin dissection are showing the features as we discussed, we need to go for pelvic lymph node. I don't think we need to go for FDG PET at any time because this protocol is quite straightforward. There are some role for FDG PET if there is any recurrence on a later date. Say for example, a patient already had a modified lymph node dissection, but it shows negative and hence the radical lymph node is not done, and then patient comes later with a disease, then your lymph node passages are already physiologically broken. So dynamic sentinel lymph node mapping won't work well. So those are the situations where the FDG PET may be useful.
Thank you. Thanks.
Any difference in what I said? Anybody read anywhere differently?
No, I think it's okay. Yeah. I think it's more in the surveillance after in the recurrence surveillance. It is used. Yeah, that was my understanding.
Good. Last scenario. Time starts now. You have 61-year-old gentleman. He was picked up from his house because he was not responsive. When the ambulance crew picked him up based upon the emergency phone call, it was quite foul smelling, and when they undressed and examined him, we had a fungating lymph node mass on the right groin and also obvious penile cancer, which is completely replacing the shaft of his whole penis. How are you going to manage it?
Right. So this patient was found unresponsive. So my immediate approach would be a systematic airway to exposure assessment of this patient and resuscitation as such. If there are any features of sepsis, I would activate sepsis protocol immediately within the hour. And then I would then, as it's unresponsive, that I cannot really take any history. But looking at the lesion, I would want to do a thorough examination once the patient is stabilized. This will include checking for any lymph node enlargement in the supraclavicular region, any abdominal mass, any palpable abdominal mass, and then I would want to properly assess the penis, looking at the depth of the lesion. Apparently, it is already involving the corpora cavernosum, and then I will have an assessment of the groin lesion. This is already looking like a metastatic penile cancer, and the aim of treatment in this case will be completely palliative. The treatment will also require multidisciplinary team approach, and so the primary aim is to ensure the patient is stabilized. I would do baseline bloods, full blood count, urea and creatinine with calcium. I would then request for CT scan, chest, abdomen, and pelvis. This will tell us if there are any pelvic lymph nodes as well, and then I would involve the plastic surgeons. I may involve the vascular surgeons because the groin dissection may the groin lesion may have involved the vessels, and then I will plan this patient for, once the patient is fully recovered, I'll plan this patient for penectomy, and then for groin excision of the groin lesion if it's possible. Otherwise, I would start this patient on systemic chemotherapy, which according to EU guideline is 5-fluorouracil, ifosfamide, and taxane.
How will you evaluate whether his groin or the penile lesion is operable or not?
So it depends on the size of the lesion. I'll try to see the fixity of the lesion. If it's completely fixed to the underlying structure, I cannot make out the vessel, then it will be a hard task going after such lesion. I know that it's challenging managing a fungating groin lesion and not being able to do any palliative resection. But if it is a dangerous thing to do going after the lesion, I would prefer to just manage this patient with systemic chemotherapy or even a palliative radiotherapy.
So, how the systemic chemotherapy is going to help you?
So the systemic chemotherapy can help to shrink the tumor and then make it operable with the aim of palliation.
Okay. The oncologist, even though it's an obvious tumor, just wants some histology to decide the chemotherapy. How are you going to take the histology?
So with this lesion that is this massive, I'll just take an incisional biopsy, taking a wedge of tissue from the edge of the lesion.
Okay. And his CT scan also showed bilateral pelvic lymph node involvement. Apart from systemic chemotherapy, what is the role for radiotherapy?
So radiotherapy is useful in this setting just for palliation. So it can be given to the primary lesion, to the groin, and then to the pelvis. And the aim is just for palliation for pain control.
What is your plan for pain control?
So analgesic, the patient can have palliative radiotherapy as well.
Okay, what are you going to do for the pelvic lymph nodes?
Well, it's already bilateral, and I would not recommend bilateral pelvic lymph node dissection because this is an extensive operation, and the aim of general treatment of this patient is purely palliative.
Okay, and he has some difficulty in passing urine. How can you help him?
So this gentleman can have partial penectomy just to remove the mass, and then leaving a stump of the urethra of the penis. and then have the urethra spatulated and catheterized.
His whole penis is replaced by the mass lesion, as I
Right.
said.
So this patient would require a suprapubic cystostomy.
Okay. In examination, what other things you are interested in this patient?
So I want to, I'll be more interested in the general, apart from the penile lesion and the groin lesion, I'll be more interested in the general state of the patient, looking at if the patient has lost significant weight, and if the patient will be able to withstand any further treatment in form of chemotherapy or radiotherapy.
Okay. And how are you going to follow him up? How are you going to explain him the long-term outcome?
So I will ensure this patient is seen by a specialist palliative team as well, and then cancer nurse specialist for support. I would explain to him that the aim of treatment is based purely palliative, and it will not require regular follow-up, as the aim of treatment is just for symptomatic control. So I will just see him in my clinic every 6 months, just to see what has changed in the meantime.
What may be his life expectancy?
The life expectancy is going to be quite poor. I'm not exactly sure with this stage of metastasis.
Okay. If there is any local breach and if he develops a kind of a ulcerative lesion, how are you going to help him with that?
Ulcerative lesion in the abdomen
in the
or
groin, in the groin.
in the groin. So any ulcerative lesion in the groin. So the main thing is to see if we could manage that by local wound dressing, and if there's any ulceration into the vessel, we might need to involve the vascular team. That may require ligation to control bleeding.
Okay, good. Unfortunately, it's not a very urological scenario. Urologically, you can't do much, but it's an exam scenario. So the only few things I will say apart from what you said is involving the palliative team, and you've mentioned many times palliative treatment, but involving the palliative team and palliative nurses, and patient may be very foul smelling, so you may have to bring in the words like I will try to nurse him in a separate single room so that he's not the other patients in the ward are not troubled, and there should be a dedicated team with appropriate deodorant for the specific room, etc. You can involve the next of kin because he's already was not very responsive, so you may have to involve the next of kin to make sure that the appropriate information is spread to the family. The next of kin may be living miles and miles away, and palliative chemotherapy and local radiotherapy may help to get some toileting effects and also to control the lesion. You should be able to bring in the wound care. So it's a lot of hospitals will have dedicated wound care or the nursing team where they will try to toilet it and give whatever the minimalistic treatment. I was expecting you to bring in the SPC placement quite early because it was a complete replacement of the tumor in of the by the penile shaft. So we need to make sure that patient is having appropriate urinary diversion, and we don't want to leave it too long and do any emergency surgery for that. And you can look into the patient's overall picture, like bringing the patient's performance status, what is his medical illness, does he had any previous cardiac or respiratory illness, any previous abdominal surgery. Local examination is very important. You are concentrating on the front side of the patient. We don't know how far it is involved behind, and making sure that his anal orifice is spared and he is able to defecate okay. And when you're doing the imaging CT scan of thorax, abdomen and pelvis, we can extend it up to the upper thigh, and you will be concentrating on the amount of the tumor burden involving the vessels. To certain extent you can preempt that there may be a possibility of like a femoral vessel involvement or vessel blown out by extending the imaging little bit, because you are almost like sitting on a dynamite. You don't know what is happening underneath the sloughy large ulcerative lesion. So by becoming a little bit more conscious on the femoral vessel involvement, you can prepare yourself. And when you're giving radiotherapy, there is a very good possibility that it can result in the vascular side effects. Chemotherapy is fine. Chemotherapy will give a different kind of shrinkage. Radiotherapy will act in a different manner. So you need to be mindful of the involvement of the way of the vessels that you can manage with CT scan itself extending a little bit more. There is not much role for like a palliative surgery, because whatever you do, it's more of a toileting effects. That is for this scenario. In the previous scenarios like modified lymph node dissection or radical lymph node dissection, try to bring in enhanced recovery protocol. Again, it is very good for radical penectomy, extended lymph node dissection, pelvic lymph node dissection, and any other tumors like prostate cancer, bladder cancer, and renal cancers, especially radical nephrectomy, I will say. Not much role for partial nephrectomy. Nowadays, patients are going home in 24 to 48 hours. Good. Any questions overall on penile cancer? It's not a very big topic.
Can I ask one question regarding the last scenario?
Yep.
For UK exam purposes, is it all right to say that once the patient is stable, we need to transfer him or discuss with the supraregional center?
Yes, supraregional you can say for everything, right from even an early stage penile cancer, unless that radical circumcision scenario you can manage in district general hospital. But if it needs like glands resurfacing, glandsectomy from that stage, the last scenario, everything is supraregional MDT. But in the exam, the easiest way is I will refer this patient to the supraregional MDT. In supraregional MDT, we will do this. So that take the role of supraregional MDT. Don't allow the examiner to say, okay, you are a supraregional MDT, tell me what you will do. Okay. So you know that's what examiner is going to say. So tell that you will bring supraregional MDT. This is for the logistic reasons. You are aware of what is happening in the present scenario, but then don't give a gap. Continue as if you are in a supraregional MDT and what you are going to do. This applies for andrology also. You can say I will refer to a dedicated andrologist. As an andrologist, we will do this 1, 2, 3, 4. We will discuss this patient in our urogynecology meeting, and as a functional urogynecologist, we will do this 1, 2, 3, 4. So don't give a gap and make the examiner to say you are the functional urologist. What will you do? Okay.
Sure. Thank you.
Right.
Good, very good. This is the last mock viva for your batch. Your batch has done wonderfully well. I'm very sure the results will be very good. We will try to make a kind of a friendly YouTube session on your exam experience, and we will certainly make a very good detailed YouTube session after the success. We will try to make something like a virtual success meeting after the exams. Keep yourself calm. I'm pretty sure the results are very good. You're going to have a good outcome. Okay.
Thank you very much.
Thank you very much.
It's been a pleasure knowing you and the effort, I must say, and I hope to give you good news after the exam.
Definitely,
Thank you
definitely.
very much, Mr.
Good,
Thank you
good.
very much, Mr. D. Your effort, it was really helpful.
Thank you. Best wishes to all.
Thank you very much.